Welcome, everybody, to the Suicide Care Research Center's public talk for April 2026. Took me a second to realize that we are actually in April. Um, they had a announcement this morning on my family's website that was of complete fake, of course, because it is April Fool's Day. We are not going to do that, but just a reminder to everybody to be aware this today that anybody could be doing anything. Um, welcome. We're going to be talking today about the use of the electronic health record as a mechanism of implementation. I am lucky enough to have four different colleagues who've been working with me over the years who have all found innovative ways to work with the electronic health record to promote suicide care. So we wanted to share a little bit of that with you. This is going to be, because there's four people speaking, this is going to be pretty brief, kind of introductory pieces, and we'll be happy to connect anybody with anybody if you're trying to figure out how to do something similar in your own system. Today we will, I'm going to put in the chat uh, kind of full, our talk for today that has full introductions of everybody, but to just do a brief introduction and then I'll have the speakers go from one to the next is Molly Adrian, Associate Professor here at the University of Washington, and who has been a lead in health services research at Seattle Children's Hospital for a long time around suicide care. Will be presenting on her work at Children's. Denise Chang, who has been working with me and some other folks at SCRC on the UW medicine build around helping primary care folks in particular to move through evidence-based suicide care sessions. We'll speak next. Then Anna Radin from the St. Luke's Health System will be presenting on the epic build that they created in order to enact their PCORI study and sort of smooth out a lot of things that a lot of us have struggled with in terms of trying to kind of make the system run smoothly and make use of a number of Epic tools for that. And lastly, Julie Angerhofer from Kaiser here in Washington will be presenting on her work that they've been doing, extensive work integrating with the Epic health system to be able to promote a number of different population-based kind of health initiatives for suicide care. And with that, I will hand it to you, Molly.
Sounds good. Thanks for the introduction, Kate. And I'm gonna share my slides here. Can people see the children's slide? Okay, fabulous. So I am going to be talking about the implementation of our suicide risk screening that is a really comprehensive and long-term effort over 10 years in about 8 minutes. So I'm going to kind of fly through what our goals were, talk through the implementation strategy, and then give a preview of some of the tools that we've used to monitor and revise our progress over time. So, when we started this work in 2017, we had really identified a goal of trying to increase the standardization of suicide risk screening across our hospital system. So, both acute care and ambulatory settings. And wanted to target this population 10 and older based on the CDC suicide deaths really in that time showing a dramatic increase in that 10 to 14 years old age group. And so we thought that the most strategic way to increase standardization was to embed the solution in our electronic health record. So that was the approach that we had taken. We started with an understanding of current state and found that we had pretty disparate and uneven screening efforts across the organization. So there were screenings occurring in a handful of different settings. It was typically done outside of the medical record and therefore not visible to anyone that screening had been done. There was no coordination across providers, departments, or clinics, and then screening was really left up to the individual provider to identify that screening was an important part of the healthcare process. So with that current state, we wanted to implement a valid and reliable screening process that provided some consistency and visibility and also supported decision making about next steps after screening was identified. So, given the setting of Seattle Children's, we have a huge diversity of clinics and processes. So, we have emergency, inpatient medical, inpatient psych, ambulatory settings that have different, healthcare specialties and different resources all across the state. And so, really needed a enormous team. This is just a small reflection of the number of people who contributed to the developing the solutions that I'm presenting today. So this effort was really supported by our quality and clinical effectiveness team, and we would not have been able to have such widespread adoption and sustainment of the program without that clinical effectiveness priority. So just I'm presenting today, but there are many, many, many contributors to this work. Okay, so we determined that what would be in scope is all of the Seattle Children's clinics in Washington. And we wanted to prioritize in-person appointments and admissions. And this group of 10 plus who were developmentally and medically able to respond. And when we started this work in 2017, there wasn't much guidance around rescreening. So we worked with Lisa Horowitz to develop our rescreening rules, which we determined would be every admission and every 30 days. So if you had an acute care admission and you were 15 days from your last screening, you would still be screened at that admission. Um, and as I mentioned, our scope was pretty broad, and we did this in a phased approach over several years. So we started in the emergency department, and then inpatient medical, inpatient psych, and then ambulatory. And ambulatory was phased over many years, which I'll show you in a few moments. We determined that the kind of best fit for our organization and age group was going to be the ASQ and BSSA and had lots of support from Lisa Horowitz on how to do that. We have screening that's able to be launched through an iPad or through the storyboard. So there are kind of three major ways in which screening can be identified. So it can be verbal administration launched through the storyboard. It can be iPad administration, and it can be some clinics if they can do it on paper. So those are kind of the three ways in which it gets administered to youth across the organization. And then we have best practice advisories that help guide risk level and cue to complete the next steps for ensuring that a brief suicide safety assessment is conducted. And then we wanted visual indications in the chart for those who were due for screening, who were also screened positive and who had safety plan supports. We wanted to make sure that all of that was had awareness across providers that those supports were either in place or needed. Okay, so with those goals in place, we had some technology support that we wanted to make sure that we embedded. So for screening and assessments, we wanted reports for missed screenings, and we wanted to ensure that you could view for an individual their history of screening and assessment. We also have several technologies for positive screens. So the ED has a track board, inpatient has pop-up alerts, and ambulatory has pop-up alerts as well as persistent alerts. We also have several sort of dashboards to show clinic compliance and positivity rates that can be filtered, and I'll show you some of those dashboards to make sure that we can kind of track how we're doing and revise our process based on those metrics. So this is the timeline of our implementation. I'm just based on time. I'm not going to belabor this slide, but you can see here that we had kind of a phased and comprehensive effort to get to our goal of being in acute care and ambulatory settings now. So we have our 33 ambulatory clinics that are have gone live by 2021, and then 89 regional clinics that have went live after that. And then we transitioned from the verbal and paper screening to predominantly iPad screening in 2022. So currently we're screening thousands of patients per month and have had pretty high compliance, though it varies a little bit month to month and clinic to clinic, but are nearing that 85% target. With that kind of broad overview, I'm going to just jump to some tools. And so you can see a little bit about how it shows up for us in the medical record. So this first slide shows kind of the process ABC for how a provider will see that a screening is due. So you can click this screening due, it brings you to the screenings tab, and then you can get to the flow sheet for the questions from the ASQ and BSSA. After that screening is completed, you get a best practice advisory guiding what the next steps should be, and if you should order a follow-up with social work and give an in-best message to the providers. You can also, if it's launched from the iPad, as opposed to that verbal administration I just showed you, you get a storyboard message that suicide risk was identified via the iPad and shows you the responses and what the next step should be for the social work order. And then you can view the past screenings in the screenings tab, and it will show you the dates and the screenings that were conducted for that child previously. And we also have storyboard alerts for the safety plan, which is kept in the longitudinal care plan, and you can access and is visible for each child who has it. After that really brief tour of some of the Epic embedded supports, I'm just going to show you our dashboards that we use across settings to understand our compliance. So we have our tracker board in the ED that shows the screenings and their results. We also have a Tableau dashboard that shows us screening compliance by date or by clinic and positivity results over time. We also have some breakdowns for high priority areas. So we wanted to understand if there was a difference in refusal rates for verbal administration and iPad administration. Maybe not surprisingly, our decline rate with the iPad administration had much higher declines because you can just exit out of the survey if you don't want to do it. And so we monitored that and we changed some of the interface on the iPads so it was not as easy to just say, I don't feel like doing this. And we increased some of our education about the reasons why we were screening when people are handed the iPad because that introduction was really missing when people are getting it from registration. So I think the kind of big lessons learned are around your implementation strategy really matters and the way that you're preparing families for getting screening upon checking in at registration is really critical. And then we continue to see opportunities for us to improve our families' understanding of what to expect at their visits, as well as how to measure our success and refine the approach to screening in our institution. Okay, I hope I'm on time. I'm going to pass to Denise. I think, Kate, do you prefer that we hold questions till the
Yeah.
end and have a discussion? Okay,
Yeah.
cool.
Let's hold questions.
All right, Denise, the floor is yours.
Hi, everyone. Thank you, um, Molly and everyone. So I'll just introduce myself. I'm Denise Chang. I'm a psychiatrist. I work at the University of Washington. My area of specialty is collaborative care or integrated behavioral health. And so I'm a psychiatrist who works with a team of mental health providers that are embedded in primary care. And so I'm presenting today on behalf of our UW Medicine team about the work that we've done here on our EHR. So a little bit opposite, I think, of Molly. We're like the beginning of our journey. I think you saw some of the really impressive things that Children's has done already. And I think we would like to get ourselves there, but we are at the beginning of this journey for us. And so we are just looking at some of these tools and how we might implement some of them in our system. So let me see if I can move these slides forward. Okay, so the agenda for today, and I have a lot of slides, so I'm going to try to go fast, but also be able to explain kind of our approach and the overview, the highlights of what we've done, what we've built, and some future opportunities and innovations as well. So for just to frame the direction we're going, we were really focusing on kind of building a suicide risk assessment tool that could be efficiently and effectively delivered in primary care and really leverage the primary care settings. As I mentioned, that's the setting I work in, but we really feel like a lot of mental health is being done in primary care. It's where the majority of mental health interventions and screening is done for sure. And then really, even though this process involves screening, assessment, intervention, and then triage, we're really focusing on how we help providers, and particularly primary care providers, do that assessment in a brief and efficient way. So how can the EHR tools help us with this? Really, if you break down kind of some of the things that we need in terms of building tools that will help support the suicide care and primary care, is provider training, which we've done a lot of, but really how can the EHR support some of that training? How can we support the use of standardized screening tools, clinical workflows, while also meeting legal and regulatory requirements, and then an ability to track metrics. So we'll talk a little bit about what is possible within the EMR, and then what we took from that and what we ended up building. So for provider training, obviously you can just do training and lots of training, which we have done, but really our PCPs have given us the feedback that, having a suicidal patient is somewhat of a rare event for them. So even though they may have been trained, really being able to pull out those tools in the moment can be difficult. So the preference really is to have that decision support or that training available in the EMR when it's happening, rather than trying to recall a training you had 2 years ago. Also, having in the EMR links to additional training guides is possible as well. For standard screening tools, if you've seen, at Seattle Children's, they have that built in. You definitely with the EMR, you can build either things that pop up or suggest or ways for you to review screening tools. There's lots of ways to build your workflow into the EMR, and we have chosen to do some customization of that, which I'll show you here in a minute. But there is a way to build tools to guide people to specific workflows and prompt them to gather particular pieces of information. From a legal regulatory requirement, you can do that really through templating, suggesting clinical interventions, and using standardized language. And then tracking metrics, I think Seattle Children's has a great example of how you can follow things, through dashboards. And then through certain tools, you can also actually track what people are selecting, and we'll show you a little bit of that as well. So when we really started our journey, it was really like not only looking at what other people have built, but what do we want to build and who will be building it for? And we did a lot of work doing a needs assessment, talking to PCPs and a behavioral health specialist within our system, trying to get a needs assessment of what people want out of the EHR tool. But really, as we talked to a lot of people, we realized, not everyone has the same sense of what they want, especially if you're coming from behavioral health or specialty, you may want something a little more comprehensive and in-depth than compared to maybe non-specialty settings. So that's sort of what we were trying to balance those needs. So we're really thinking about where will this work be done? As Molly pointed out, very wide ranging, and you're not in a health system. You have outpatient ambulatory clinics, you have inpatient, you have ED, you have urgent care. So there's lots of places. Again, our first focus was really on primary care, primarily because, primary care providers aren't necessarily specialty trained and they won't have already set workflow for this, whereas our behavioral health teams, do more risk assessments more frequently. So they already have a system in place likely. So we really want to focus on primary care because we felt like that's where we could have a bigger impact. And then we thought about who was going to do this work. So physicians, obviously, but also advanced practitioners, nurses, possibly trainees like residents, maybe medical students, and possibly even medical staff like medical assistants. So really thinking about who in the greater scheme of a health system is going to be interacting potentially with a suicidal patient and how they might be utilizing or interacting with this potential tool. And the idea here was really to build a base model with primary care in mind, and then potentially considering laying on future enhancements in future iterations that might meet the needs of more specialty providers. So this is what we built. I'm going to go over these and do a demo of each of these, but you're familiar with Epic and that landscape. There are 4 things that we built. One was a navigator, a note writer, then a smart set and express lane, and I'll explain all of those in a minute. But the key here, I think the approach that we took was try to make it flexible. Like there's multiple ways to get to the same thing. So there might be different front doors, but all the information will flow to the same place. So that was our intention, is building these different avenues. So now I'm just going to move into showing you a kind of screenshots and drafts of what we built to give you the sense. Again, these are drafts. They aren't actually fully in production. We're finalizing. And again, as Paul pointed out, this is summary of like 2+ years of work. So we're really distilling, giving you just the highlights. There's a lot more depth and nuance into this, but just giving you kind of an overview of what we've done. So Navigator, if you're not familiar with a Navigator is, it's really a customized workspace which has sections in it that really guides a clinician through a workflow. And the beauty of it is that it really consolidates information, streamlines documentation, and ensures that we are providing standardized care. So here's an example of a Navigator. It's kind of like, if you think of it, it's like a tab on your window in Epic. The way we built it was, the first thing we did was do a screening history page. That's where you would land first. So if someone filled out a PHQ-9 or a Columbia, for example, that would be the first thing for you to review. So it's not necessarily for you to input new information, but oftentimes MAs or other people, or even like if you're using iPads, people will have already self-put in answers for the questionnaires. And this is for a provider. If the suicide if their suicidal ideation comes up as part of the visit, they can pull this up and they'll see those screener answers already here. So that's for review. And then next section, so I should, the left-hand side here is kind of like the menu bar, if you will. Like this is the sections that we're asking people to go through. So first will be the screening history. Second will be the suicide inquiry. So this is really the meat of the kind of content of trying to ask the questions of, getting more details around patient suicidal thoughts. So here it basically prompts those questions for a provider to ask about suicidal thoughts, attempts, etc., including lethal means. So that's a snapshot of what that would look like. And then next section would be risk and protective factors. We did highlight this as potentially optional for our PCPs, because as you can imagine, they're in like 10-minute visits or 15-minute visits. But if they do select it, they can select, either the presence or absence of both risk factors and protective factors, and we've color-coded them here. And the nice thing about, I should have said, both the suicide inquiry that we just saw and these are smart forms, which means that they're saved. So as you make these selections, they're saved to that patient. So if there is another provider that comes and opens the chart next week, these selections will be present, and you can update and change them, but you don't necessarily have to start from scratch each time. So that's the risk and protective factors. The next section is basically a checkpoint for providers to basically ask themselves, is there an imminent safety risk concern right now? And if so, we have them kind of choose yes or no. And if it's a yes, we really are basically saying stop, don't go further, really. You really need to initiate safety precautions right now in terms of, thinking about sending the patient to the ED or doing a warm handoff to some other behavioral health team. So it's really kind of saying like, that's the direction we should go, and then giving them some intervention recommendations right away about that. But in most cases, you can imagine imminent safety is probably not happening. So then if it's a no, then it's more just like, okay, continue on, but consider these things, and consider reducing, modifiable risk factors, enhancing protective factors, consider appropriate resources, referrals, etc. So as you continue to go on to this pathway, the next section would be safety planning. And here we're guiding patients to the guidance of what, our suicide experts have, guided us to, which is for moderate to high risk patients, really completing a safety plan, and it's right there for them to click on and open. If it's a low risk patient, a full safety plan is not required, and that we really encourage them to do the recommendations that we just showed, which is, modifying risk factors, consider referrals and resources, and we already have some dot phrases for them to include that already have some crisis info for the patient as well. So that's safety planning. And then the next section, is for safety planning, we also have this optional clinical decision support. So as we talked about training, having that available to people as they need it. So essentially, if you don't know, is this a low risk patient? Is this a moderate to high risk patient? And you're not sure, you can open this up and it'll expand this risk stratification table, including recommended interventions below. There's also a link, as we mentioned, to additional training or additional information if they wanted. And then we're really pointing people to the VA MyRec clinical practice guidelines. So that's the link there. So here's a guidance again. If you're new to this process, you're not as familiar with how to assess risk, here's a clinical decision support guide for you. And then moving now to the kind of last piece of wrap up is really assessing that risk, assigning a level of risk to that patient, and then interventions, and then documenting that. So having an overall risk assessment, low, intermediate, high. We already have some preset justifications of level of care to help people with their kind of documentation and meeting those standards in terms of also legal and regulatory. And then documenting your plan. So meaning like what actually happened? Was lethal means done? Was safety planning done? And then also guiding people to kind of comment on certain things that would benefit the patient in terms of like suicidal patients being referred, or efforts to increase their connectedness. So this is the assessment. I'm going to keep going in the interest of time. This is what the clinical note would look like. Basically, the note gets generated based on those selections. So as you are clicking boxes, then you can produce a note already, and these are refreshable text. So if you went back and changed, you could refresh your text and it would reflect those changes. The next big thing I wanted to show you, so switching gears, that was the navigator. So imagine that was like a kind of a tab where you can like one-stop shop, get everything you need. Note writer is similar, but coming from a different angle. So some note writers are functionality or an activity within Epic that's a way to generate notes through kind of a point and click. This allows for increased efficiency, and also things like you can automatically generate charges based on certain selections that are made. So those are some of the benefits of using Note Writer. Note Writer is where you can basically call up the tabs in a different way. But again, that's the idea, is you coming it from a different angle, but essentially the base and where the information flows is the same. So here, this is kind of, we left open a box where people could type in kind of like the scenario of what's happening with the patient, the information that's gathered from the patient. But then quickly it goes to the same thing. And then we'll go over this in detail because we just reviewed the same sections, but just kind of in a different format or a different presentation. So here you can have the suicide inquiry. The next is the risks and protective factors. Similarly, you can select the boxes. And again, these are saved, so then you can kind of update as needed if the patient has been seen before, action steps as before, and then overall risk formulation again. So again, the same thing, same content, just presented in a different way, or accessed in a different way. The note is similarly generated, but as you're clicking, the note's actually generating for you on the right-hand side of your screen, and as your selections are being made. So that's what Note Writer looks like. The two other things that we built are built off of kind of a different framework, if you will. Smart sets are kind of similarly a bundling of documentation, decision support, order sets, patient instructions, all into a single workflow. Again, it helps with efficiency and standardization. It just looks a little bit different. So it's more like a checkboxy type of approach. So you can pull up a smart set, and then you can click these boxes to which ones you want to add. If you want to add the node, if you want to do a safety plan, you want to add the instructions, you just check off which ones you're doing. For our system, our providers are pretty familiar with smart sets, so that's one avenue we think that they will probably engage with is a smart set. Their note writers may be newer for our providers, as is a navigator. So smart set, we can imagine that our providers might be more used to that format. A newer thing that's available in Epic is something called an express lane. It's very similar to smart sets, but it's basically a suggested smart set. So it's presenting the workflow, and it allows them to work onto a single screen and reduces the amount of clicks that they have to do. And the nice thing about express lanes, it can be suggested or triggered automatically based on certain things like a chief complaint or other criteria. Kind of similar or contrasting a little bit to Seattle Children's, where they were doing a best practice advisory, now called our practice advisory. It's a pop-up. That is possible. I'll just make a comment that we avoided the pop-ups because our providers in our system get a lot of pop-ups. And so our comment early on when we were designing this was they don't want any more pop-ups. They have plenty of pop-ups, and they basically just click it to just make it go away. And what we were trying to do is something a little more subtle that still suggested, oh, we see that your patient is having this issue, a suggestion, but not a directly in your face pop-up. Maybe we will get there eventually, but as a buy-in, we heard them loud and clear that they did not want pop-ups to start. So we went with the Express Lane, which is a newer option. We had our draft one that we're building to be triggered off of a positive PHQ-9. So imagine this is your, rooming your patient. You start with like the PHQ-9, and let's say the patient had on the question number 9, anything but a 0, that would then pop up this down below. If you look at the bottom of the screen, this little icon that basically suggests an express lane, and then has this box. So then you can click on that box, and then this is what you would see. So you're already in your node, you're working. It very much looks like a smart set, and that's why they're very much similar. But then if you click on, add the note, then you get to the same note that we were just showing you, the note that we built, so that it kind of is a suggested pathway, and it still has all the ability to do all your orders and do your documentation. So I'll just wrap up really quickly about kind of some of the lessons we learned so far. As I mentioned, we haven't implemented this yet. We're still wrapping up the building phase and hope to implement soon. But what we have heard from the many iterations where we've gone back and get feedback from providers is that primary care providers in particular want a streamlined version. They really want to focus on what are the actual essential steps to be able to do suicide risk assessment. And then PCPs, for the most part, are really case finding and triaging, meaning like they're usually finding out someone's suicidal and then having to triage what to do. They're not always in the business of managing chronic suicidal risk. So that perspective, I think, is important when we're working with primary care providers. Also, choices that we decided to make was that we weren't mandating a specific suicide screener. In fact, we were kind of agnostic with that. It could be a PHQ-9, a CSSRS, or an ASQ. We were using more that screening review that no matter what tool was being used, that you can see and review what answers may have been asked, or questions that have been asked and what the answers were. And we really focused on what works well for a provider. So if there was a take home here, we built multiple versions of this, partly because we want to integrate into what our providers are already using and what they're used to. If we try to introduce a brand new tool and a brand new workflow, it's not likely going to get used. So if they use smart sets, great, we have a way for you to get to this workflow through a smart set. If you like NoteWriter, great, we're going to give you an option to do it through NoteWriter. And the reason why we did so much work to do multiple ways of doing it is really helps with buy-in, because if you're trying to introduce something new, especially for a workflow that's maybe a little uncomfortable for them, we really want them to feel comfortable with the tool. But we also will say this is an opportunity to introduce new tools. So as we maybe are getting them comfortable with the smart set, we may then slowly introduce them to the express lane, which is going to be new for most people. And that way they can maybe make a transition to something that might be a little more efficient. And maybe we'll transition them to that pop-up tool eventually as they get more comfortable with the workflow. So lastly, the benefits of using these tools are really, our approach was of focusing on more of a population approach and a primary care approach. And leveraging that setting, we can have that population data for both quality improvement and research. So this population data will help us have a better understanding of our population, like what kind of risk factors are we seeing in this population? What are we seeing in our setting? That will help us, potentially think of new and more appropriate interventions that might be needed. So again, if we're seeing common risk factors for our population, we might then be able to pair that with something that might be more appropriate for our patient population. And then also by having these boxes that people can click, we can collect user information. So we can collect data on every time, how many people selected this, box or this reason, and we can actually use that information around future enhancements of the tool itself. So I think we're saving questions for the end. I'll say thank you and pass to the next provider, but also say thank you to our Epic partners and Lucas, who also helped us. So Jamie, Patrick, who helped to build this tool, and Lucas that has been doing it. And of course, this is like Care Research Center. Thank you.
Thanks, Denise. I'm going to jump in next, I think. Hopefully I'm in the right order here. I'll be talking a little bit about the evolution of our Epic Care or suicide prevention care workflows at St. Luke's Health System in Idaho. I want to start by letting folks know that I'm not a clinician, so I was not one of the end users of this, but did help with some of the design work. And like Molly and Denise presented, we had a huge team of people that put a tremendous amount of work into this. So it is mostly not me that came up with all the good ideas presented here. Really quickly on St. Luke's Health System, we're a large nonprofit health system in Idaho with 9 medical centers, about 20,000 staff, including about 1,400 physicians and around 200 ambulatory clinics. So a fairly large health system. A couple of things just to give you a sense of what we focused on, like Molly and Denise in their work, we were really trying to work towards reducing unnecessary care variation. So we want to allow flexibility where there should be flexibility, but not just have this Wild West where everybody does whatever they think to do. So we really focused on screening, assessment, safety planning, and safe disposition planning. Those were kind of the 4 areas we focused on. We rolled this out between 2019 and 2020, and we had a pretty detailed custom Epic build through about 2023, at which point St. Luke started reverting back to some of the new, well, not reverting back, reverting forward to some of the new standard build tools that were available in Epic for the first time. So I want to share what we did way back when, before those tools were available. So in terms of screening, and I'll focus on primary care, we did this work across multiple settings, but it gets complicated to discuss what was happening in the ED and primary care and everything else at the same time. So in primary care, we had patients self-completing a full Columbia on the iPad or through my chart a few hours before their visit for every provider visit during this time period. So we did a lot of screening. We actually were able to get pretty high rates of compliance. I think we were in the 89 percentile most of the time for our primary care clinics. And that's across about 60 clinics. We then used the safety assessment, which patients would complete with their primary care provider, or if that clinic had a collaborative care or integrated social worker, they could do that with them, or we had an option for virtual video visits that they could stand up. Similarly, with the safety planning intervention, they completed those in the same way. And we developed a custom Epic Smart Form, including both the safety planning intervention and a version of the SPI that we developed with Greg Brown and Barbara Stanley called Connection and Support Planning, together with Kate and some other folks at UW, that we would implement with low-risk patients who were not clinically appropriate for a full safety planning intervention. And then lastly, for safe disposition planning, we had some resources and tools to help support making referrals, including to our research study, SPARK, that was comparing the effectiveness of 2 different forms of follow-up care. So I've got a little bit in here about the research Epic workflows too, in case that's interesting to anyone. So to start with screening, I mentioned this was every provider visit, the patients were completing these Columbias on the iPad generally, or if they did it in my chart a few hours before the visit, they could do it at home. We administered items 1, 2, and 6 of the Columbia to all patients, and then for those patients that responded yes to either 2 or 6, then they cascaded to items 3, 4, and 5 as well. For patients that had a positive screen, meaning any answer of yes to items 1 through 6, the first thing that happened was our patient access staff were notified. So we had them wrench in a suicide risk column into their multi-provider schedule so that it would populate automatically with a red, yellow, green, or a blank or gray or something square, which I'll show you on the next slide. That indicated to the PAS staff what level of suicide risk that patient had just endorsed on their Columbia. Then the PAS staff could consider things like ligature risk prior to rooming patients and make sure that the room they're going to put them in was safe for them. They could also select an exam room that could accommodate a longer visit for safety planning if that was an option at the clinic. Not all of our clinics had that option, but some did. And then also, if they knew that their provider was a provider that used the virtual social work option, or if they were a clinic without a collaborative care social worker, they could work with that patient to get a MyChart account stood up or help the patient find their password, that kind of thing, so that they would be able to do a video visit with the social worker if needed. So that was all kind of PAS functionality that we built in with the screening. Then we also had BPAs set up, similarly to what Seattle Children's did, to notify providers of the suicide risk. Those pop up and open immediately. Our providers also often click out of those and close those and dismiss them, but there's a really easy way from the storyboard to pop them back open when they're ready to circle back to that risk. So they did not find that problematic. This is probably not the best screenshot because you can't see the whole multi-provider schedule, but this is essentially what PAS would see. So they'd see either green, yellow, orange, or red, depending on the risk level for the Columbia completed that day for the patient. These are the 3 BPAs at either low risk, moderate risk, or high risk that providers would see. And you can see that they get a link to, well, first, a brief overview of suicide care that's recommended based on the triage level, and then also a link to the Columbia flow sheet so they can review that patient's screening history, see their specific answers to the Columbia today, but also at all previous time points in St. Luke's. And then they can also easily open the smart sets for the safety assessment, safety planning, and connection and support planning. So this is the build we did for the safety assessment. Really, the goal was to make it as quick as possible for providers to click through rather than having to do a bunch of typing. And you can see that there were easy ways for them to then pull that into their progress notes. This is the smart form that we built for safety planning and connection and support planning. We built that out as a single form, recognizing that patients' risk may be high risk one visit, low risk the next, or start out at low risk. We wanted to make it so that if a patient had developed a connection and support plan and then their risk elevated in the future, that the elements of the CSP that were relevant to a full safety planning intervention would automatically populate and pull into their SPI so that when they're going through that with their provider, they're not starting from scratch. Similarly, because it's a smart form, they can easily open this providers. It's very easy to find. It shows up in the storyboard here. So any provider at St. Luke's can click open and it'll show the latest version of the CSP or the safety plan that that patient completed. And then the provider can review, sign off, and it'll timestamp it with their signature. They can make any changes and it saves previous versions as well as the latest version. Let's see, there's a bunch on this slide. I'm sorry. We used smart phrases to help with notes as well as the smart sets that you can see there. This was in like 2019, early 2020, so really before everyone was doing virtual video visits. So this was one of the first forays into virtual video visits that we had at St. Luke's. And we had all these iPads deployed and this new MyChart video visit workflow stood up just before COVID hit, which wound up being really, really fortunate. But we have ways. So first for doctors or physicians or providers to place the order for the virtual social worker using the suicide risk smart set, which you can see there. Our team of collaborative care social workers had a pool so that those that were not busy with a patient could pick up patients from other clinics in maybe more rural areas that didn't have a collaborative care social worker so that they could take on those patients and support safety assessment and safety planning for them. Then originally we had video visits stood up for study enrollment for our PCORI-funded SPARK trial as well. We had to recruit 1,500 participants, which is a large number, and half of them were adolescents, which is why we built this into Epic to support recruitment. Ultimately, we realized that recruitment went much better and our clinics liked us a lot more if we did that piece at home. So we built an easy referral option with one click in the BPA, the suicide risk BPA, that allowed providers to refer the patient to Spark, and then our research coordinators would upload an EPIC report and could text patients using Mosio after they returned home. So that worked better because it didn't keep the patients in the clinic any longer. We didn't have to bother with video visits, and worked pretty smoothly. And then lastly, the other piece of EPIC functionality we used for this study, our community partners at the Idaho Crisis and Suicide Hotline were the ones delivering our interventions. They are not EPIC users, but we really wanted them to be able to see our research participant safety plan, our connection and support plan. And so we used EPIC CareLink to be able to push those plans, as well as the Columbia screening history to EPIC CareLink, so that our team at the hotline could log in and see those parts of the medical record that were relevant for the research. So we spent a lot of work on the design, build, and testing. There's a bulleted list there of the things we built out. We built the Columbia screeners, the EPIC BPAs, the smart sets, the safety assessment form, the safety plan smart form with the connection and support plan built in, the workflow for the MyChart video visits, and also the EPIC CareLink piece that we shared with our community partners, relevant pieces of the medical record. We spent a lot of time focused on training and change management because this new workflow impacted all the roles you see listed there, from patient access to clinical staff, providers, social workers, our research team, as well as our partners at the hotline. We had great support during go live and focused on break fixes, and then over time had to stand up processes to prioritize enhancement requests, because you could, as you can imagine, with so many people impacted, lots of people had lots of good ideas about how to make this better. So this slide is just to show you how many folks were involved in this work. It really was a tremendous team effort from all across our health system. And I think our primary lessons learned were, number one, and I think Molly, you touched on this too, but really the importance of having a comprehensive training and communication plan in place, especially when multiple roles are impacted by the EPIC workflow. Second, the importance of change management and listening sessions across all clinical roles. I can't tell you how many lunches I spent listening to providers complain about what they didn't like and tell us what they did like, and just really needing to take that feedback. But at the same time, balancing that with too many changes, people get frustrated with that as well. And then the last lesson we learned is that there's a significant lift required, obviously, to design and launch this kind of EPIC build. But we learned, and we're not fully expecting how much work it was to maintain a custom build, because every time EPIC updates, then a lot of things in our custom build would break. And so it was really a tremendous amount of effort to maintain a custom build, which is why ultimately we reverted to or moved towards the EPIC standard build. We did lose some core functionality that we still really miss. We can't include the connection and support plan for low-risk patients. We've lost the ability to take feedback from our lived experience advisors on things like they feel very strongly about including reasons for living on a safety plan, and we can't do that if we use the EPIC standard build. So there are just some things that are really nice about a custom build that we don't have as much flexibility with using the standard build. But I will stop there. I think Julie's up next. So thank you all for your attention.
Thank you, Anna. So I'm not going to show slides today, but I'm just going to talk through a few things that we've done at Kaiser Permanente. I'm going to drop in the chat some of the references to the work that we've done, and I'll reflect on those in just a second. So I guess I should introduce myself, though, just in case there are folks on the call that I don't know. I'm Julie Angerhofer. I'm also not a clinician. I work with clinicians and patients to improve the care that we provide, mostly in my region in Washington, but Kaiser's serves patients across 8 states, about 12.6 million people currently. So I also work with folks at the national level to do some of the work that I'm going to describe. So reflecting on some of the presentations so far, like Molly and Anna just described, Kaiser's been doing this work for quite a while. We started in 2012 in our mental health specialty system, and then we started spreading the work to our primary care system in 2015. So those papers describe what we did, and we evaluated the effectiveness of that work. That's been published now in the last few years. A few coming attractions I'll describe. We're now evaluating the effectiveness of suicide care and primary care for teens. That's going to, my colleague Gwen Lapham is working on that work here. There's also quite a few students that are involved in some of the evaluations that have come out of the work that we've done. So in mental health specialty, we're also evaluating the effectiveness of integrating care for teens. That's going to be Taylor Ryan, a PhD student here at UW, is doing that work now using our zero suicide data set. We're looking, I had a master's student I worked with looking at patterns of suicide risk identification among Black youth. And hopefully we can share that in future presentations. I won't go into it now, but it's really interesting. That was a lot of fun to work with Brittany on that. I have a student now who wants to do some work on cost effectiveness, Megan Wincoop. So hopefully you'll be able to hear from her in future presentations. We've also done a lot of qualitative work talking to people about how they perceive, suicide risk identification tools like screening, assessment, and suicide risk prediction algorithms. So suicide risk prediction algorithms are really like where we've moved in the last few years. So I'll share a picture on my screen in just a second of what we're trying to do now so basically what we're trying to do is augment existing screening and assessment protocols to like help capture the people who maybe aren't reporting suicidal thoughts for a variety of different reasons that we've got into in our qualitative work. I will say that the tools that we've developed so far, we've really tried to do some of the things that Denise and Anna described, really reduce the friction between providers and the tools that we've used to like kind of enhance our suicide care. So I think that's just a really important thing, and we continue to do that with using suicide risk prediction algorithms. So I'll share this on the screen. This is a huddle card that we sent out just recently. So it describes, oops, can you guys see that? Probably not. Yeah, you can? Okay, great. So it describes kind of what the goal of this is. So this is a picture in the upper right-hand corner of our existing workflow and kind of how we've tried to integrate use of risk prediction algorithms. There's also one screenshot up on here of the DAR, the department appointing report that our check-in staff use to like help figure out what tools people should get when they come in for their appointment. So here, actually, I'll show the mural board. I just wanted to give you a sense of that it's, this work is messy. So what we try to do is get in there and kind of embrace the mess. And then we try to really figure out like what tools that we need to try to like tackle to improve the workflows that we're doing. So really the goal of the work that we're doing now is taking patients, identified adults, we haven't moved into teens yet, identified in the top 5% of risk via these suicide risk prediction algorithms. Suicide risk prediction algorithms currently take all of the information that we know about demographics and mental health care and assign like a threshold of a scaled risk like marker. And we create a binary variable that identifies like patients in the top 5%. Some of those patients are already engaged in mental health care, which is great. Many are not. So what we've done now is mostly patient facing. So these patients now all receive, some additional suicide screening and assessment to help support, them getting the care that they need. Luckily, as part of all of the work that I popped into the chat, we've put a lot of like supports in place in primary care so that when patients are identified, they are, if they're in crisis, like their crisis providers available to do safety planning. There's also a lot of like processes in place to connect people to future care. So I'm going to stop talking because I think we're almost at the end of the hour, but I do just want to reflect that, all of the information that we've shared today, Kate, you were absolutely right. We have so much information that's really important to share at Epic UGM. So that's the Epic user group meeting, which is like this huge conference in Verona, Wisconsin, that happens in August. So not an ideal time probably to travel to Verona, Wisconsin, but Kate, Denise, and I are going to be going this year and sharing all of the, well, some of the information, probably not all of it, because there's so much that we just covered in the last hour, to our colleagues at Epic, and hopefully be able to continue, disseminating a lot of these amazing tools that have been developed across all of our systems. So I'm going to turn it back to Kate now.
Thank you. Thanks to everybody. Like I said, this was, we've done a lot of work. And so this is really just scratching the surface of what all of this work is. But I think it's really important because a lot of folks have not seen this kind of work, even among our center. Not everybody in the center has seen what Julie's doing versus what Anna's doing versus what Molly is doing versus Denise and I. So we really just wanted to have this as a kind of initial share out. I definitely think that if there are, Macy has put the link to our evaluation in there, and if there are particular parts of this kind of Epic integration and using Epic as an implementation tool that people are interested in, please flag that in the evaluation form because, at first I just feel like we've all done a lot of work and people should know about it and people should have a sense of the possibilities. That's what I'm hoping you all got from this discussion, but I think in the future we're going to dig into individual areas and we can reflect on how we've all kind of dealt with particular Epic tools or different elements of the pathway. So we'll do that in future meetings. Thank you all so much for coming, and we'll talk to you all next month. Take care. Bye.